Thomas Weimbs here, the president of Santa Barbara Nutrients. It was my great pleasure to sit down with Dr. Osama Amro for an interview. Dr. Amro is the director of the PKD Center of Excellence at the Swedish Hospital in Seattle, in Washington. So it's a large hospital, and they have a dedicated clinic for people with polycystic kidney disease. So in the interview, we're talking about what the center does, what the different features are, the experts, and also Dr. Amro's kind of philosophy on how he actually treats his patients. And if there is a patient out there, they probably would want to listen to this to see what a really high standard of management and treatment of polycystic kidney disease can look like. So enjoy the interview. Hello everyone, Thomas Weimbs here, president of Santa Barbara Nutrients. Today's guest is Dr. Osama Amro. From Seattle in Washington. He's the director of the Swedish PKD Center of Excellence up there. And it's a great pleasure to have you here. We've known each other for a little bit, back and forth, have discussed PKD and so on. So I'd say let's dig a little bit deeper. And see what we can come up with. So my first question is, who is Osama Amro? Where do you actually come from originally, and how did you get to Seattle eventually?
Oh, thanks very much, Thomas. We always pleasure talking to you. I am originally from Jordan. I trained in Cleveland for internal medicine. Then I did my fellowship and clinical research fellowship in nephrology at Tufts in Boston. And my wife happened to be from Seattle, so she dragged me all the way to Seattle around 8 years ago. And my interest in PKD started in Boston, in which we conducted industry and NIH-funded clinical trials in PKD, and I helped Dr. Perron at Tufts to maintain the PKD registry over there. I really strengthened my passion to help these patients with the complex disease of PKD. So I moved to Seattle, and I always tell people I complain to everybody else about the lack of sun, except my wife. So this is, but I kept the windows open today just to show that we get some sun every now and then.
Nice.
So I moved to Seattle about 8 years ago to Swedish, and around 4 years ago we established the Swedish PKD Center. And a few months back, we got the designation as Center of Excellence with providing comprehensive multidisciplinary approach for PKD patients and this complex disease. We currently manage over 250 AD-PKD patients in Seattle.
Wow, excellent. And just so for folks out there that may not, be from Seattle, so Swedish hospital is not in Sweden, right? It's, I believe, the largest hospital in Seattle. Is that right?
It's one of the largest. It's a big tertiary center in Seattle, and you're right, Thomas. It is named after the person who originally created the hospital, and happens to be from Sweden. So this is a common confusion.
Right.
Correct.
Wonderful, great, excellent. So you went to you did your nephrology training at Tufts. You mentioned Tufts in Boston, and working with Ron Perron. Sounded like, is that right? Excellent. Yeah. So, and I guess that's was the connection to ADPKD, and that's how you got started in that field. Okay. Excellent. Yeah. So I'm wondering if you can tell us more about the PKD Center that you have started there at Swedish. So the PKD Foundation they have recently started to designate centers as centers of excellence. And that means there's certain criteria. You have to have like a certain number of services and so on, and experts on. Maybe you could describe what the center is all about and how it looks like.
Yeah, this is really important. Center of Excellence, the core requirement of Center of Excellence is to have a multidisciplinary team. I always say, to take care of complex disease like PKD, you need a team. You don't need a person or a specialist is not enough because it affects multiple aspects of patient's life. And the most important person in the team for the PKD is the patient. So everything revolves around the patients and the patient's requirement based on the manifestation of the disease. As firsthand that nutrition is really important part of any complex disease. So we brought a nutritionist who will help us out with guiding the patient through nutritional guidance through PKD. Then the PKD can affect the kidney function, obviously, and we have nephrologists who are trained and familiar with PKD. PKD can affect brain aneurysm, can cause brain aneurysm. So we have a neurosurgeon who is familiar with PKD, and we brought all this collaboration together under one institution with a goal to have a home for these patients to get all their care related to the PKD at Swedish PKD Center of Excellence. And other requirements is to continue to try to improve the outcome in patients with PKD by participation in clinical research, which we do. So we do a clinical part of management of PKD. Also, we participate in clinical research. So, and that's mainly the requirement, having a multidisciplinary approach, multidisciplinary team with experience in managing PKD, revolving around patient need and participation in clinical research.
Excellent. I guess as a nephrologist, PKD is probably your main specialty. I'm sure you probably also see, some other diseases as well. And you mentioned you have other specialists as well. How about transplantation? Is that something one can get, hooked up through your center?
Yeah, that's correct. So it depends on the stage of the disease.
Right.
Obviously, as you know, PKD can lead to progression in around 60% of patients affected with PKD will end up with kidney failure. And having a transplant center or transplant service is really crucial. So we do have transplant nephrologists who are familiar with the PKD, transplant surgeon who is familiar with the PKD. So providing the care regardless of the stage of the patients in PKD progression. And it's really important to have the transplant service, the ability to remove the affected kidney at the time of transplant, so to provide the patients a comprehensive approach.
Excellent. All right. How about pediatric? Do you see pediatric patients as well?
We don't see pediatric. I don't see pediatric myself. However, in our center, we do have a pediatric nephrologist who specialize or interested in PKD, which we refer all the pediatric referrals to her, Dr. Avasari. And as you know, this is a familiar disease, so patients sometimes interested to screen family members, screen children, and this population we refer to our PKD pediatric nephrologist. So you're right, Thomas. Really try to think about all the aspects of the disease, and all stages of the disease, and try to have a comprehensive team that will help with that.
Excellent. And you mentioned research. What kind of research is going on? Are you involved in?
So we generally do a clinical trial, not basic science research. So we do clinical trial. We mainly do a phase 1B, 2, and 3. So we recently we have bardoxolone trial, the Falcon trial. Then we had a precision trial, which is a trial looking for software to evaluate the total kidney volume, and then we are participating in anti-microRNA trial for PKD, which is the Regulus trial. So we try to really recruit patients for any active PKD trial. As you know, this disease, the battle is really still on, and we really try to manage the disease, try to find a treatment or meaningful progress in the future, and that's part of participation in clinical trial.
Excellent. And I believe this is like very recent. I believe the bardoxolone trial was actually stopped, at least for CKD. Did that affect the PKD trial?
That's correct. We received, this is a constant reminder how complex the disease is. Last week we got the notification that a bardoxolone trial or Falcon trial will be terminated, and that's due to futility. Basically, in a lay terminology, that it is unlikely to be effective and it's unlikely to be approved for the PKD. And this is really devastating news for all of us in the PKD community, because we constantly looking for progress, breakthrough in the PKD. And that's a constant reminder that we are really dealing with complex disease. We need every help possible. We need help from patients, from scientists, from nutritionists, from every help possible, because Thomas, believe it or not, this is the third trial that has been terminated in the last 3 years. And I'm talking about phase 3 trial. This is like advanced trial, either through because of futility or safety. So we're really need to continue the battle, need to continue our fight against the PKD, because that was really a sad news that the bardoxolone was terminated recently. So again, we will not give up. We will continue the fight, but we are looking for other alternative treatment, other alternative trials.
Right. Excellent. So I'm wondering what your philosophy is, in how to manage and treat people with PKD. And obviously they come in a huge spectrum, some very early stage patients, some very late stage patients, ready for transplantation or having to go on dialysis. So there's only one approved drug, tolvaptan, which I'm assuming you're probably using in some patients. What are some of the, what is your thinking? A new patient comes in, how do you usually figure out what works for them, or what is most likely to work for them with their lifestyle and so on?
So the strategy is individualized. Basically, we need to understand our patients. We need to understand their lifestyle, and we need to understand their work, their family, and we need to understand their disease very well. Because, as you know, not all PKD patients will progress to kidney failure, and we really need to treat them differently. So if patients are to progress to kidney failure, or they are at risk of rapid disease progression, we treat them differently. If patients have a milder disease, we treat them differently. So understanding the patient and understanding the disease, this is where our ground zero, we start there. We want to understand what is the disease trajectory for this particular patient and what's their lifestyle. How can we craft a plan that is suitable for this patient, that set this patient for success? So when the patients come to our clinic, first we verify and confirm the diagnosis, and the next step we start to understand the patients. What do you do for work? What do you do for activity? What do you do for diet? And you will be surprised how a lot of opportunities arise from understanding the patient. So if the patients come to us and their typical breakfast is Jimmy John's, McDonald's at lunch, and pizza and dinner, we have a lot of work to do. So we really understanding the patient, help you understand the next plan of action, and then understanding the job circumstances. Is a job that require a lot of traveling? Is the job requiring prolonged hours? Is there an access to the bathroom? And what type of food that's available for the patient during the working hours? So these are really important. Is a nighttime shift or daytime shift? So that is understanding. And if there is a major event coming for patients, like a wedding, change in job, like I remember one patient, he was planning to join the police academy, so we delayed the intense portion of our plan until his intense training is complete. So we want to make sure we individualize the care in a way that set the patient for success. Once we understand the patient, then we craft a plan regarding diet. And as I said, some patients will require a lot of dietary counseling, and some patients little. So everybody's different, and based on that, we'll refer to the appropriate plan. And then we start to understand the disease trajectory, and that's usually involve more detailed imaging. So we look at the imaging of the kidneys with MRI usually, and we want to try to identify how big is the kidneys for this age, and what's the Mayo Clinic imaging classification, which will help us determine the disease trajectory over time.
Right. Excellent. Yeah. So you mentioned the Mayo Clinic classification. Maybe you could explain it for some folks that may not be very familiar with how that works and what it tells you and so on.
Very good. So the Mayo Clinic imaging classification is dividing patients based on the disease trajectory or the slope projection of disease progression. And the patients in the Mayo Clinic imaging classification of ADPKD divided into 5 stages: class 1A, B, C, and D, and E. And 1A, 1B, these are the patients they don't have very large kidneys, and their disease will progress slowly. So that means, in a lay terminology, these are patients unlikely to end up with kidney failure, or if they end up with kidney failure, it's going to be at advanced age. Class C and D and E, these are patients with larger kidneys. So basically, it's dependent on how big is the kidneys are, which is called the total kidney volume, how big the kidneys are based on the age and height. And class C and D and E, these are the patients who will progress in a slope that will lead to kidney failure at early age. So these are the patients we really will need to pay attention early on and try to treat them differently.
Mm-hmm. Excellent. Yeah. So in a sense, it's almost like a snapshot. So depending on how old someone is, you look at the total kidney volume. If somebody is young, has a very large kidney, that's bad. That would probably put them into 1D or something like this. If someone is already very, very old, has medium-sized kidneys, then they might luck out, so to speak, and have a much slower progressing disease. Wonderful.
Correct. Well said. Well said. So basically, how big is the kidneys for this age, and which category patient will progress? What's the slope that's expected
Right.
for this patient?
Excellent. So now a question that I always see on, I have a Facebook group of something like 3,000 members. Well, most of them are people with PKD, and there's a lot of discussion going on. Some patients don't have the luxury to be treated in a center of excellence such as yours. There might be under the care of a private practitioner that may not even have any other patients with PKD, may not be very familiar with. I've heard many stories like that. So what many patients get told by practitioners is, you have a genetic disease, there's nothing you can do, go away, come back in a year, and as you get closer to dialysis, we'll put you on a transplant list, and there's nothing you can do yourself, which I think if I were a patient, I would be extremely frustrated if I get told, there's nothing you can do. I'm assuming you don't share that philosophy, and you actually give people lots and lots of options of what they can do, even besides drug intervention. So I wonder what your strategy there is.
Yeah, I do agree. A completely passive approach is really not the way to go. I tell the patients every little things count. A nutritional supplement, nutrition, low salt diet, high water intake, blood pressure control, weight control. Every little thing we do, even if it caused a little dent on the disease trajectory, that's a progress. So I really don't share a passive approach for these patients. I know we are not there, we don't have a cure, we don't have something that will hold the disease, but every little thing that the patients do can help. And the way I tell the patients, if they encounter, a practitioner or an nephrologist that they have a very passive approach for the disease, push them a little bit. Our PKD patients are very educated, so push them a little bit. What about this? What about this? So not only this will provoke thinking, also will change the thinking for this particular nephrologist. Okay, maybe we should think about this, and they can always seek more care in a more advanced center, but definitely push their nephrologist. Okay, what about this? And educate themselves. This is a complex disease. Any help we can get from patients, from advocacy group, PKD Foundation, from anybody, it's helpful.
Wonderful. I totally agree, and I think it's really empowering for patients to at least be told, there are these 5 options that I want you to work on. Start with one, and next time we work on the next one. So that's excellent. So what type of diet and lifestyle changes do you usually recommend?
That's a very good question. So first of all, I tell patients that limiting salt intake is really important. and we go through hidden sources of salt, cold cut, canned food, things that people. I had patients tell me that they don't have a shaker at home, but when you look at the sodium intake, it's really massive because it's a lot of processed food. So I think low salt intake is really a cornerstone of the diet related to the PKD, and moderate protein restriction. So we don't restrict the protein a lot, but moderate protein restriction, which is about 0.8 gram per kilogram body weight. If they do heavy exercise, we can go up to 1 gram per kilogram body weight per day. And that's a moderate protein restriction. And believe it or not, Thomas, this is the recommended for healthy individuals. So this is like a healthy diet, regardless whether you have the disease or not. But unfortunately, it happens that in the United States, we consume so much protein and so much salt. Then I talk to patients about leaning toward more vegetable-based diet, basically an alkaline-based diet. So leaning more toward vegetables diet. Then recently, with the emerging data of ketosis, I have been pushing patients to do some intermittent fasting, especially if they are overweight. I feel that this will set the metabolism to help with that. And data, although limited data, suggests that ketosis or starvation will slow the disease down, slow the cyst down. Although our data is limited, but we have the safety data is robust, so we know this intervention is safe, and there is really potential to slow the disease down. As I said, especially if there is an overweight component. And what I advocate for intermittent fasting is 16 hours of fasting from calories, and 8 hours they are allowed to drink and eat. To eat. They are allowed to drink water throughout the day, but 16 hours of void of any calories. So we tell them have a early dinner and late breakfast, but no calories in between, and they can do it twice a week. They are welcome to do more than that, but that will set their metabolism and induce the ketosis, which is hopefully will slow the disease down. And in addition to that, we advocate for water, high water intake.
Right, excellent. Yeah, so you mentioned keto. That's of course something that's near and dear to my heart. And that's something we've done a lot of research on and studies on. But oftentimes, when doctors hear keto, they're afraid of it, and they're saying, "Whoa, this is dangerous." I wonder if it has to do with like a little bit confusion that ketosis and ketoacidosis are often confused with each other, and I wonder what your take is. And it's fantastic that you're not afraid of keto, and there's a lot of more and more doctors and practitioners are coming to sort of like low carb ketogenic metabolic therapy. So I wonder what your view is in general.
You are right. It's a lot of confusion, and I don't advocate for a purely ketogenic diet. I think in the long term, this is likely will not be safe. So I don't advocate for a patient to be completely devoid of carbohydrate. I don't think this is a healthy diet in the long term. What I advocate for is inducing a status of ketosis or limiting the carbohydrate, and the status of ketosis by 16 hours of fasting, like basically having the body go into the starvation, the ketosis, and that will not only data showing on limited data on PKD, but remember there is data to suggest that the cancer risk will go down, the metabolism and the obesity will improve. So there is a lot of data coming compelling that intermittent fasting or inducing the ketosis is beneficial. Now the frequency might not be fully known, so it's reasonable to do 2 days a week, or a little bit more or a little bit less, but we know that as a principle this seems to be beneficial in multiple levels. And you're right, it's just trying to avoid the extreme diet of ketogenic diet, which I don't think in the long term is safe.
Okay, excellent. So, and we've talked previously about KetoCitra as well. My understanding is some of your patients are using it as well. I wonder if you have any experience so far, any feedback from them?
As a principle, I think KetoCitra carries two advantages: the keto supplement and the citrate. And we know that PKD patients are at risk of oxalate stones and crystals, and a lot of our patients we used to provide potassium citrate supplement for that. So I think it is reasonable, and we have a few patients who are using the KetoCitra. It is reasonable to start KetoCitra, especially if patients who have kidney stones before, or kidney stones present in the X-ray finding in the CT scan, MRI. I think this is reasonable. Although I caution the patients that although the data is limited, it seems like as a principle this might help with their disease trajectory. But again, we lack long-term data. I hope we will have these. So this is an alternative or an option that these patients use. Another group of patients that sometimes I advocate for KetoCitra, patients who cannot tolerate the intermittent fasting. So I feel that this is an alternative. Believe it or not, sometimes not easy for lifestyle to tolerate the 16 hours of fasting. So I feel that they might get the benefit of the keto supplement or ketosis if they take the keto supplement rather than doing none of them. So if they are unable to do intermittent fasting, what is the alternative? What's the option they can do? So these patients, I said, okay, it might be reasonable to take the keto supplement in replacement of intermittent fasting. So these are a group of patients I feel they might benefit from KetoCitra. In terms of the actual experience, most of the patients who took KetoCitra in our center overall tolerate the medication reasonably well. I don't recall significant reported side effects that prompted discontinuation of the medication. Again, our experience is limited. We are growing our experience with the supplement, but these are the two group of patients that in general I feel they might benefit from KetoCitra.
Right. Oh, excellent. And you also have dietitians that you work with. I know Nikki, and maybe you have others as well, and they're somewhat affiliated with the center. I wonder what the kind of like the triangle, the patient, the nephrologist, the dietitian is, and how this plays out for you.
So Thomas, think of this. They come to the clinic and I tell them a general guidance. But they actually need a plan, right? The patients need a plan. They need to know, okay, what do I have for breakfast? What do I have for lunch? What I provide the patient is a general guide. What I provide, okay, I want you to reduce this. I want you to increase this. But I don't provide them a plan. You need somebody to guide them through the plan, and somebody who is really patient and familiar with what is needed, and a craft plan that's suitable for you. If you like cooking, your plan will be different from somebody who's really dependent on eating out, for example. The options are different. So again, to summarize this, we have Nikki Gabner, who works with us at Swedish PKD Center. She's a really great patient and spends some time with the patient. Translate the guidance into a plan. And I think that's what you need. The nutritionist essential role is to translate the guidance from the center or from the physicians to a plan that can be adopted and lived with in a day-to-day. Because patients cannot live, people cannot live in very limited options. You need to provide options to have it sustainable. You can stay on an extreme diet for a month, 2 months, then people will get sick of it. You need to have a plan that's sustainable. You need to have a plan that patients can live for the rest of their life or for a prolonged period of time, and they can enjoy their life. The goal is not to restrict the patient to the degree that it is becoming very burdensome to the patient. Restriction by itself is very hard. We don't want to make it harder for them by limiting this.
Right. Wonderful. I totally agree. That's fantastic that you're working closely with dietitians. I'm wondering, practically, do patients often do they get the dietitian time reimbursed through health insurance? How does that work?
Yeah, Thomas, this is a very important question. Most insurance provide some support. I think we just need to guide the patient through the support from the insurance. Many times what happens is the insurance limit the visits time. So instead like two visits, one visit. So that will be challenging. But I tell the patients just take the most out of this visit or two visits or three visits. And many times patients will end up with some burden from financial burden, which is really sad. I hope the insurance view of the nutrition and the medical community view the nutrition will change, because I don't feel this is a secondary way of management. I feel this is a cornerstone of management. You know, it is it is not wise to add a blood pressure medication when you can reduce the blood pressure with a reduction of salt. There is definitely time in which we have to add blood pressure medication, but we need to exhaust every possible nutritional intervention before we do that. So I feel of this as a hand-on-hand management strategy, the diet. And even when for the patients who are appropriate for tolvaptan, their tolerance to the tolvaptan varies by their adherence to low salt diet and low protein diet. So it's not only important for the disease itself, it's important for the tolerance to the medication, because as you know, the side effects of tolvaptan is frequent urination and frequent excessive thirst, and that's worse if the diet is high salt and high protein. So it is really not only important for disease trajectory, it's important to tolerate the medication if they are appropriate for tolvaptan.
Wonderful. And of course, there is the the Renew program you mentioned before we started, that some of your patients are in it. It might be too early, to have have feedback from them yet. But that's if somebody wants like very intensive work with a dietitian, something maybe that doesn't normally would get reimbursed by health insurance. If they're able to pay for it themselves, that would be an option. And hopefully you'll get some fantastic feedback from your own patients there. And as you know, we're also starting clinical trials. So hopefully we'll have some long-term outcomes there. Be fantastic.
I think this will really be important, not only to provide the scientific community with justification of any intervention, also will help the insurance, will help justify the insurance coverage of all these interventions. I think of the program, whether the combination of KetoCitra or without KetoCitra, as a really crucial, and the dietary counseling is crucial part of the treatment. And I really hope that we reach a point in which really this is part of our reimbursement in the insurance. I really hate to have this patient burdened by any financial burden in addition to their disease burden. Like, we really need to reach to a more holistic comprehensive approach of managing PKD.
I totally agree. Yes, preventing something is better than curing something. Absolutely. Also, then actually, sort of, this leads me to kind of my final question: where do you see the management and treatment of ADPKD, let's say, in the next 10 years? What do you think is on the horizon? What will happen day in, day out in your practice, you think, in 10 years?
I think the biggest change we will see is the paradigm of treatment in terms of realization when to start the management. I think now we have a better understanding that the disease is the cyst and the cyst is the disease. We do not need to wait for the eGFR to decline to start the treatment. And I think we are starting slowly to adopt this as a community. Okay, I want to know the disease trajectory. I don't want to wait to see the disease start to show itself before I start the treatment. And early intervention that involve medical intervention, dietary intervention, lifestyle modification. In terms of the medication, so this is the main change. I think people, physicians, nephrologists, internal medicine, now coming to realization, okay, I need to start the treatment early on. I need to start dietary changes early on. I need to start blood pressure control aggressive early on. I need to risk stratify the patient very early on. So that's the first change I see in the next 5 to 10 years, and I think this will solidify. The next phase of the medical treatment, in addition to incorporating lifestyle and dietary counseling, is a multi-targeted approach. I do not see that we are in a place in the next 5 to 10 years that we will have a medication that will hold the disease by itself. I do think that some of the targeted approach that we are studying, looking at, might be successful, and we have to multi-targeted approach for this disease.
Right. Wonderful. I couldn't agree more. That's amazing. I think to anyone out there that's watching this, if you want to see a doctor and a whole team, that really knows a thing or two about ADPKD, make your way to Seattle. How can people actually get treated by you? Do they have to be in the local area? Do you also get people from further away that travel? How does that work?
Yeah, our catchment area is vast. We are the only center of excellence in Washington, Oregon, and the surrounding states, Alaska. What we usually do, we realize that we really need to get the patients with PKD access to care instead of waiting months before they're seen. So what we end up doing, dedicated a day in the week for PKD patients. Now, patients are welcome to come on other days, but they have protected time in every Thursday. This will allow access, will reduce the wait time significantly. So our wait time for PKD Center is about 3 months, and believe it or not, this is substantially lower than it used to be. So about 2 to 3 months, they will have access to be, after their referral, to be access to be evaluated. And a lot of time what we usually do, and a similar approach which I learned from Dr. Perron at Tufts, like, we provide a one-time consult if needed, and if we see, okay, everything is going okay, you are on the right path, you can continue your treatment at your regular doctor or regular kidney specialist, you are on the right path, or we suggest an addition or some adjustment of the plan, and again we send them back to their nephrologist. This way they get the comprehensive evaluation, but they are not burdened by coming frequently far away from home. So they get the full evaluation without sacrificing their time and the time they enjoy with their family.
Wonderful. Great, Amro. Thank you so much. I would say last word goes to you. Is there something we forgot to talk about, or some message you want to put out there to patients or maybe to your colleagues? Up to you.
I would say hats off to you and your team and every PKD specialist, every PKD patients, every person interested to help this patients with this disease. As you know, we had a lot of setbacks. I mean, we have been working with PKD for many years, right? And we had a lot of setbacks. So we really need every effort. We really need everybody who is helping us progress in this disease, really hats off to them. We really need all the help. All hats off for all the patients who participated in clinical trial or willing to participate, all the nutritionists who put the effort, programs, all the scientists who try to come up with a target for treatment. So everybody who works in the PKD community and the PKD Foundation putting a lot of effort, a lot of resources in form of grants, in form of educational programs, hats off for all of this. I think we need every effort we can get. We're gonna continue the fight. I always joke with my trainee and my colleagues that I'm gonna retire when the last gray of my hair, once we find a cure or meaningful breakthrough through the PKD. So we're gonna continue the fight, and hopefully we'll get there.
Wonderful. Thank you so much, Dr. Osama Amro. Thank you for spending your time with us. Excellent. Great. Thanks.
I appreciate it. Thanks.